Welcome to the second lecture in a series of lectures on pediatric cardiac anesthesia. In this talk, we will be discussing preoperative assessment. Preoperative assessment of the pediatric cardiac patient with congenital heart disease is an important component of preoperative anesthetic care. The assessment of such patients follows the usual basic principles of preoperative assessment. In the history, details should be sought regarding the cardiac condition, complications, associated syndromes, medications, their cardiopulmonary reserve, dental and vascular status, birth and developmental history. Previous anesthetic and surgical care records should be reviewed for medical therapy, interventional cardiac catheterization, or previous surgical correction. The patient's current weight should be noted, as they may have failure to thrive due to impaired oxygen delivery and increased cardiac metabolic demands. Physical examination focuses on the volume status, signs of cardiac failure and cyanosis. Investigations which should be reviewed include vital signs, full blood count, electrolytes, renal panel, coagulation and blood typing, as well as the latest electrocardiogram, plain radiographs of the chest, cardiac ultrasound, MRI, CT scans or cardiac catheterization, if any. One risk stratification model we may be familiar with in adults is the New York Heart Association classification. In pediatrics, the modified Ross score is used for children less than 6 years old. For easy reference, here are the physiological parameters and hemoglobin levels for different age groups. We first need to understand the lesion the patient has. This involves reviewing the pathophysiology of their cardiac lesion, the types of repair they may have undergone or are planned to undergo, and the imaging modalities available. As outlined in the first lecture, CHD lesions generally fall into one of these categories. They can be also broadly grouped as non-cyanotic and cyanotic heart disease. Examples of each category are shown in this table. It is useful to parse them into these categories when assessing a patient, to quickly understand intraoperative cardiac physiology. Your patient may have had previous surgical repair which alters their cardiac physiology. 50% of cardiac surgeries are done in the first 1 year of life, and the more severe lesions such as obstructed or duct-dependent lesions may have needed surgery within the first few days of life. There are two types of surgery, corrective and palliative. Corrective repair aims to protect the ventricles from volume or pressure overload, to prevent future deterioration of myocardial function, as well as avoid development of pulmonary vascular disease. This includes VSD and transannular patch repair of tetralogy of Fallot, and vessel rerouting such as in the arterial switch repair for transposed great arteries. Such patients have normal life expectancy after repair, if the cardiac remodeling is reversible. Repair is palliative if corrective surgery is not possible, or the cardiac remodeling is irreversible. Most repairs result in an increase or decrease in blood flow either to the pulmonary or systemic circulation, but the right and left ventricles are not rematched to their respective pulmonary and systemic circulations. Hence the cardiac chambers are not protected from volume or pressure overload, and after a period of time, the patient may develop complications such as cardiac failure and arrhythmias. The life expectancy is thus shortened in such patients. An example of palliative repair is a systemic pulmonary shunt to increase pulmonary blood flow in cyanotic heart disease where the patient has a single ventricle physiology, such as Blalock-Taussig shunts, Glenn shunts, and the completion Fontan procedure. Another example is the aim to decrease pulmonary artery blood flow in cardiac lesions with left to right shunts, such as pulmonary artery banding. Procedures to enhance pulmonary venous blood flow may be performed in patients. These procedures include atrial septostomy, or even atrial switch using a baffle to redirect venous return to the left atrium, in cases of TGA. Finally, procedures to optimize systemic blood flow such as the Norwood operation can be performed. A new aorta is constructed using the pulmonary trunk graft but arises from the right heart, the PDA is ligated, and a sono shunt may be implanted to supply blood to the pulmonary arteries. To understand the lesion, one also has to review the cardiac imaging. The four main modalities are cardiac ultrasound, cardiac catheterization, cardiac MRI, and ECG-gated cardiac computed tomography. Each form of imaging modality has its own advantages and disadvantages. This is expounded upon in the third lecture on cardiac imaging. Once we have understood and categorized the lesion, it is useful to note that each category has different presentations, such as pulmonary hypertension, ventricular failure, and cyanosis. However, as the disease progresses with time, all of these may develop. For example, a left-to-right shunt may result in pulmonary overload and pulmonary hypertension, which over time results in right heart failure, congestive cardiac failure, and bidirectional Eisenmenger shunt, leading to cyanosis and ventricular failure. Additionally, any lesion may present with arrhythmia or murmurs on examination. We will go through these presentations one by one. In an infant, pulmonary hypertension often develops due to increased pulmonary blood flow from left to right shunting. It is defined as a mean pulmonary arterial pressure of more than 25 mm mercury at rest, and a pulmonary vascular resistance of more than 3 Woods units. Pulmonary vascular resistance can be calculated by subtracting mean pulmonary capillary wedge pressure from mean pulmonary artery pressure, and then dividing the result by the cardiac output, much like the equation where resistance is equal to pressure over flow, in physics. Pathophysiologically, excessive pulmonary blood flow results in vascular wall shear stress, which then results in proliferation of the tunica intima, hypertrophy of the tunica media, and fibrosis of the adventitia. This reduces arborization, which causes pruning of pulmonary distal vessels, reduction of pulmonary compliance, and increased respiratory resistance and work of breathing. It impacts the cardiovascular system by causing right ventricular hypertrophy and Eisenmengers, which is defined by mean pulmonary arterial pressure more than 50 mm mercury, or pulmonary vascular resistance of more than 10 Woods units. Ultimately, this leads to right ventricular failure, which is a marker of poor prognosis, and presents with raised jugular venous pressure, peripheral and sacral edema, hepatomegaly and ascites. Right atrial pressure has been shown to correlate with end organ dysfunction. It is important to note that pulmonary hypertension in these patients may be multifactorial. For example, a child with Down syndrome may have an atrioventricular septal defect, but may also have obstructive sleep apnea, gastroesophageal sphincter hypertonia and reflux. On the electrocardiogram, or ECG, the patient may have supporting signs of right heart strain or hypertrophy, with P pulmonale implying right atrial enlargement, and right axis deviation. A chest radiograph and bedside echocardiography will help delineate any structural cause for the increased pulmonary blood flow. If a cardiac catheterization is done, it can measure pulmonary vascular resistance or PVR, ratios of right to left ventricular pressures, as well as assess the response of PVR to oxygen, inhaled nitric oxide, and intravascular vasodilators. Patients who have a systolic pulmonary arterial pressure of more than half of their systolic systemic blood pressure, or PVR more than 4 Woods units, have been found to have significant perioperative risk. Surgical correction of the inciting cardiac lesion is contraindicated if the pulmonary vascular resistance is more than 40% of the systemic vascular resistance, or if the mean pulmonary arterial pressure exceeds mean systemic arterial pressure by 70%. This chest radiograph shows the features of a patient with pulmonary hypertension. The central pulmonary artery is prominent, the apex of the heart is elevated due to right ventricular hypertrophy, and the distal pulmonary vasculature is poorly visualized at the peripheries of the lung fields due to pruning. Cyanosis is another feature the patient with congenital heart disease may present with. It can be defined as a state where the deoxyhemoglobin concentration is more than 5 grams per deciliter, and its manifestation depends on several factors. Firstly, the more concentrated the hemoglobin is, the earlier cyanosis occurs during desaturation. A polycythemic patient with hemoglobin of 20 will be cyanosed at an oxygen saturation of 80 to 85%, whilst an anemic patient needs to desaturate to 50% before he appears cyanotic. Secondly, at the same partial pressure of oxygen, blood containing fetal hemoglobin will be of higher oxygen saturation than blood containing adult hemoglobin, and hence the fetal hemoglobin desaturates and manifests cyanosis later than adult hemoglobin. Finally, the location of cyanosis can differ, such as the case where a patent ductus arteriosus is the cause of the right to left shunt. If there is productal coarctation of the aorta, where the coarctation is proximal to the PDA, the deoxygenated blood only mixes with oxygenated blood distal to the left subclavian, and hence only the lower limbs appear cyanosed. If the coarctation is postductal, then the upper limbs will appear cyanosed as well. Cyanosis also depends on the extent of hypoxemia, which is affected by several factors. Firstly, oxygen delivery to tissues depends on both by oxygen carrying capacity, as well as cardiac output, which is comprised of heart rate and stroke volume. In neonates and infants, stroke volume is fixed, and they depend on tachycardia to increase cardiac output. Going back to basics, oxygen carrying capacity is affected by hemoglobin concentration, partial pressure of oxygen diffusing into the blood or PaO2, and oxygen saturation, or SaO2. Partial pressure of oxygen in the alveoli is affected by fraction of inspired oxygen in the air, humidity, arterial partial pressure of carbon dioxide, and respiratory quotient. Any change in these factors can affect the oxygen delivery to tissues. Secondly, because of the right to left shunt, arterial oxygen saturation is also affected by factors contributing to venous oxygen saturation, or SVO2. These include the rate of oxygen uptake as well as cardiac output. If cardiac output drops, SVO2 drops, which lowers the SaO2 further after shunt mixing. Thirdly, the lower the ratio of pulmonary blood flow, or QP, to systemic blood flow, or QS, the greater the degree of cyanosis observed. Finally, here are some of the effects of chronic cyanosis. An increased hematocrit is a physiological response to cyanosis, to increase the oxygen carrying capacity of the blood. However, polycythemia results in hyperviscosity, which can lead to microvascular occlusion and venous thromboembolisms. The constant turnover of the copious bilirubin may also lead to cholelithiasis, which may be complicated by cholangitis and jaundice. Secondly, there is an increased bleeding tendency and fibrinolysis, due to a decrease in von Willebrand and vitamin K-dependent factors, and platelet count. With a higher hematocrit, PT and APTT tests may be inaccurate as well, due to increased citrate to plasma ratio, when the blood is added to a standard vacuum collection tube. Next, there is a greater tendency for chronic ventricular dysfunction and vulnerability to ischemia. Once the hematocrit is greater than 60 to 65%, hypoxemia and hypoperfusion set in, as the myocardial workload is greatly increased from the higher viscosity of the blood. The renal glomeruli is similarly affected, and manifests with a thickened basement membrane, hyperuricemia and proteinuria. Patients with cyanosis due to shunts are vulnerable to brain abscesses, as the blood bypasses the natural host defenses and filtering capillary network present in lung parenchyma. Patients with intracardiac shunts are also at risk of endocarditis. Vegetations form when a high-pressure jet of blood enters a low-pressure cavity through a narrow shunt orifice, resulting in clumps of platelets, fibrin and infective organisms forming on the edges of valves. Preoperative investigations aim to delineate the severity of the cyanosis and the presence of complications arising from it. Commonly, the SpO2 is less than 85%, and if the patent ductus arteriosus is the source of the shunt, a preductal and postductal SpO2 can be measured on the appropriate limbs. If a full blood count is done, evidence of polycythemia in compensation for hypoxemia may be seen. On an arterial blood gas, the partial pressure of arterial oxygen will be low, indicating the central nature of the cyanosis. If the partial pressure of carbon dioxide is high as well, central neuraxial as well as pulmonary causes need to be investigated and eliminated. If the pH is low, the patient may be in sepsis or circulatory shock, and the hypoxemia may be quite severe, necessitating acute management. In patients with chronic cyanosis, their pH should be compensated. On the electrocardiogram, the pathology of the congenital heart disease may be elucidated. Right ventricular hypertrophy manifests as right axis deviation and tall R waves in right-sided leads, as well as P pulmonale A waves which indicate right atrial enlargement. Tetralogy of Fallot may have the wide QRS and RSR' waves of right bundle branch block, and transposition of the great arteries would show an atrioventricular block. Additional investigations include a plain chest radiograph, which will be elaborated on in the next slide, and a bedside transthoracic echocardiogram, which will reveal the cardiac pathology. If resources allow, a hyperoxia test can be performed in the clinic to rule out pulmonary causes for cyanosis. The patient is administered 100% fraction of inspired oxygen for 10 minutes, and if the patient remains cyanotic, in the presence of a cardiac pathology, the cyanosis is likely to be cardiac in origin. The first plain radiograph shows a boot-shaped heart. This is a sign of right ventricular hypertrophy, and occurs in conditions such as tetralogy of Fallot and the Vactal syndromes. The pulmonary artery also has a concave shadow, and if you look beyond the mediastinum, you can see the rib and vertebral deformities of the Vactal syndrome. This next plain radiograph shows an egg on a string appearance of TGA. The enlarged cardiac silhouette is an egg lying on its side, and the narrowed mediastinum is the string. The mediastinum often appears narrow due to the D-loop transposition configuration of the great arteries, where the main pulmonary artery is more to the right and posterior to the aorta. The thymus is often atrophied and the lungs hyperinflated, adding to the narrowed appearance. The right heart border is convex and shifted to the right, indicating right atrial enlargement, and there is a double contour shadow of the left atrium within the right atrial shadow, indicating left atrial enlargement due to increased pulmonary blood flow. This also results in pulmonary hypertension and causes upper lobe vessels to become prominent, also known as the antler sign. The last plain radiograph shows the snowman sign of TAPVR or total anomalous pulmonary venous return. In type 1 TAPVR, the four pulmonary veins coalesce at the supracardiac level to form a vertical vein, which commonly drains into the innominate vein. The head of the snowman is formed by this dilated vertical vein on the left, the superior vena cava on the right and the innominate vein on top. The body of the snowman is formed by the enlarged right atrium. In the other three types of TAPVR, the pulmonary veins empty into one or more veins of the right heart, at the cardiac or infracardiac level. A right-to-left shunt is crucial for survival in these patients where blood is constantly circulating and recirculating from right heart to lung and back. Besides pulmonary hypertension and cyanosis, the patient with congenital heart disease may also present with ventricular failure. The onset of failure depends on several factors. If the systemic ventricle is initially right-sided, it is more prone to failure as the myocardium is thinner and withstands systemic circulatory pressures poorly. Furthermore, the right ventricle requires perfusion throughout the cardiac cycle, as opposed to the left ventricle which is only perfused in diastole. Hence any increase in right ventricular transmural pressure which reduces coronary blood flow, may result in ischemia. Even if the right ventricle supplies the pulmonary circulation as per usual anatomy, a systolic pulmonary arterial pressure of more than 50 mm mercury, or more than half of the systemic systolic blood pressure will precipitate right ventricular failure. Having an early repair, as well as a corrective repair, also helps to protect the myocardium from remodeling, and the spiral of hypertrophy, ischemia, and failure. Volume overloaded ventricles fare worse than those which are pressure overloaded, as they are extremely sensitive to increased afterload, which may fluctuate physiologically. However, a pressure-overloaded ventricle is also at risk of failure, due to a low tolerance for oxygen supply-demand imbalance to the concentrically hypertrophied myocardium. As mentioned earlier, cyanotic patients are also treading the fine balance of myocardial oxygen supply and demand, and this balance may be tipped with the slightest exertion, resulting in a low threshold for hypoxic myocardial dysfunction. Finally, myocardial ischemia can also result in ventricular failure, and this can be due to multiple causes in the pediatric patient, including coronary malformations, post-surgical correction events, microvascular occlusions, and exacerbation of pulmonary arterial hypertension. The signs and symptoms of ventricular failure are different depending on the age of the child. In the very young, the parent may give a history of feeding difficulty, dyspnea and intolerance to longer periods of drinking milk, delayed growth, failure to thrive, apathy, weak cry and irritability. On examination, one may observe tachycardia, extreme inspiratory effort using accessory muscles of respiration, as well as signs of congestive heart failure with hepatomegaly and sacral edema. If the child is less than 2 months old, ventricular failure is more likely to be due to structural heart disease. In older children, their growth may be stunted, and they may report exercise intolerance, fatigue, dyspnea on exertion, orthopnea, and cardiac symptoms such as chest pain, palpitations and presyncope. On examination, they may display signs of cardiac failure such as pulmonary crepitations or rhonchi, jugular venous distension, peripheral edema, and effects of poor perfusion, such as slow mentation, cold clammy peripheries, and even sluggish urine output. Investigations specific to ventricular failure include doing a serum brain natriuretic peptide, or BNP, with a value of more than 100 picograms per milliliter indicating congestive cardiac failure, although the upper limit of normal may be slightly higher in neonates. Serial measurement of serum BNP allows for prognostication of acute decompensated heart failure, where persistent elevation or a slow decline of BNP may be observed. Cardiac enzymes such as troponin may also indicate ischemia secondary to coronary anomalies, or global hypoperfusion if the patient also has overlying sepsis. On assessment of electrolytes, the patient may have dilutional hyponatremia from fluid retention, hyperkalemia with raised serum urea and creatinine due to acute or chronic renal injury, and hyperlactemia and low bicarbonate from tissue hypoxia. The ECG is likely to show a left or right ventricular hypertrophy or strain pattern, depending on which is the failing ventricle, and there may be concurrent AV block and arrhythmia, such as atrial fibrillation from upstream dilated atria. A plain radiograph and transthoracic echocardiography will identify any anatomical culprit lesions and assess the myocardial function. This is a plain radiograph showing one type of patient with ventricular failure. This patient has cardiomegaly, where the cardiothoracic ratio is more than 0.55, usually due to volume overload, valvular regurgitation, impaired myocardial function and resultant dilative cardiomyopathy. It is possible to have ventricular failure without cardiomegaly, however, and this occurs in restrictive cardiomyopathy, venous obstruction or diastolic dysfunction from high ventilation pressures. The bronchovascular markings may be increased or decreased, depending proportionately on pulmonary blood flow. Staging of congenital cardiac disease is based on the ISHLT classification, which stages from A to D based on heart structure and function, as well as on the presence of heart failure and the therapy required. For example, a patient in stage D may require ECMO on standby intraoperatively, whilst those in B and C can be treated medically. Specifically for pediatrics, the modified Ross classification can be used for those below 6 years old. A high classification has been shown to correlate with a pulmonary capillary wedge pressure of more than 15 mm mercury, and the more limited the cardiopulmonary reserve, the higher the risk of perioperative morbidity and mortality. Patients with congenital heart disease may present with arrhythmia. In children, especially infants, cardiac output is heart rate dependent, due to the inability to significantly increase the stroke volume. However, once the heart rate is more than 170 beats per minute, ventricular filling and cardiac output is compromised. Tachyarrhythmias can be divided into atrial and ventricular in origin. Atrial tachyarrhythmias tend to occur with a rate of 180 to 300, and usually have narrow QRS complexes less than 80 to 100 milliseconds on ECG. They are commonly due to atrial dilation and postoperative scarring, especially from atriotomy. Some examples include multifocal atrial tachycardia, ectopic atrial tachycardia, junctional ectopic tachycardia such as supraventricular tachycardia, and atrial fibrillation or flutter. Ventricular tachyarrhythmia often occur due to myocardial abnormalities, which can range from ventriculotomy scars to cardiomyopathy, whether dilational or ischemic. These include ventricular tachycardia and fibrillation. A common treatment for most tachyarrhythmia is amiodarone. However, in postoperative junctional ectopic tachycardia, vagal maneuvers and overdrive pacing are the treatment of choice, as it is resistant to cardioversion and adenosine. This ECG strip shows multifocal atrial ectopics, with polymorphic P waves indicated by the arrows. A run of junctional ectopic tachycardia is seen here highlighted by the shaded box, where P waves are absent as the electrical impulse initiates from the bundle of His. This is ventricular tachycardia, which manifests as broad QRS complexes and a discordance between the direction of the QRS and the T wave. Conversely, older children, toddlers and neonates tolerate slower heart rates less and less well, with the minimum heart rate for adequate perfusion being 70 in a neonate, 60 in those less than 2 years of age, and 50 in those older than 2. Bradyarrhythmias can be divided based on their causes: sinus node malfunction, atrioventricular block, or bundle branch blocks. Sinus bradycardia may be iatrogenic, during SVC cannulation, or postoperatively from long atrial suture lines. Atrioventricular block may be due to the congenital disease itself involving the great vessels or the chamber walls, or postoperatively after VSD correction, AV canal defect repair, or tricuspid valve surgery. Bundle branch block may be due to ventricular hypertrophy or scarring. These are the indications for pacemaker implantation. The bradycardia should be severe and persistent, and at least 7 days postoperative. This is narrow complex sinus rhythm at a rate of around 60 beats per minute, which although in an adult may be physiological, in this 11-month-old child is considered sinus bradycardia. In this ECG, the PR interval is greatly prolonged, due to an atrioventricular block. This last ECG shows left bundle branch block. It is evidenced by a dominant S wave in the right-sided leads V1 and 2, and a broad monophasic QRS complex more than 120 milliseconds in V4 to 6, with a M-shaped RSR' pattern. In these patients, preliminary investigations include electrolytes and hemoglobin levels, a baseline ECG, as well as a 24-hour ambulatory ECG to record and characterize the arrhythmia. The patient may also have an implanted cardiac rhythm management device, which includes implantable cardioverter defibrillators, permanent pacemakers and cardiac resynchronization therapy. Preoperative evaluation includes taking a detailed history on the indication, timing of insertion and capabilities of the device, and examining the patient's cardiovascular system and marking the site of the device. Investigations to look through include an ECG for presence of pacing spikes, a plain chest radiograph for the location of the generator, as well as any pacing lead breakage, and device interrogation report for battery life, pacing dependence and response to magnet. Intraoperatively, drugs which lower the intrinsic heart rate should be avoided if the patient is not pacemaker dependent. These include Precedex and remifentanil. The myocardial stimulus threshold for mechanical capture is also raised by hyperkalemia, hyperglycemia, blood acid-base imbalance, as well as hypothermia, so it is important to avoid these states to ensure good pacemaker function. This plain radiograph shows an implanted permanent pacemaker, evidenced by the single solid component, the battery, and its epicardially placed leads. Finally, patients may also present with a cardiac murmur. Innocent murmurs due to physiological turbulence of blood flow tend to be louder in supine, be short and early systolic, soft, and without any palpable thrill or systemic manifestations of congestion or cyanosis. A child needs to be at least 1 year old for a murmur to be clinically dismissed as innocent without further investigations, as a cardiac pathology may not have had time to manifest itself and its complications within the first year of life. Conversely, a pathological murmur would be louder on sitting up, due to the reduced preload. It would also be holosystolic or diastolic, loud and harsh, and may be accompanied by other physical signs such as a thrill and peripheral edema or cyanosis. A child may also have differential pulses or systolic blood pressure in different limbs due to coarctation, or if a BT shunt has been created from one of the subclavian arteries. In such cases, the IA line should be avoided on the side of the BT shunt due to reduced arterial blood flow and inaccurate reflection of the systemic blood pressure. A child who has had multiple hospitalizations and surgeries may also have difficult venous access, and it may be helpful to ask the parents where the best veins can be found. 10% of congenital heart disease occurs in association with chromosomal abnormalities. Some genetic conditions are shown here, each with their specific commonly associated cardiac pathology. Often, they have systemic manifestations as well, which require assessment and optimization, from developmental delay which may affect cooperation with induction, to renal anomalies which may cause chronic renal impairment and need caution with renotoxic drugs and peri-op monitoring, to vertebral and limb deformities that may preclude central neuraxial anesthesia or require attention to positioning intraoperatively. Importantly, most genetic syndromes are associated with airway anomalies. Obstructive sleep apnea, microcephaly, micrognathia and macroglossia all predispose to difficult intubation. Atlantoaxial instability, especially in Down syndrome, may result in spinal cord injury during airway manipulation. Subglottic stenosis and a short trachea needs careful attention to ETT sizing and depth. Restrictive lung disease with scoliosis or pectus excavatum will reduce the functional residual capacity, shorten apnea time, may necessitate high ventilator pressures with risk of barotrauma, and together with hypertonia and poor cough, predispose the patient to a difficult extubation, postoperative atelectasis and respiratory complications. In patients who have anomalous great vessels, this may result in the phenomenon known as a vascular ring, which compresses mediastinal structures such as the trachea and esophagus. In some patients, this may be due to a right-sided aortic arch and ligamentum arteriosum, in others it may be due to a double aortic arch. Patients with a double aortic arch present earlier, even when less than 6 months of age, with a biphasic stridor that is worse during feeding or an upper respiratory tract infection. In older children, a vascular ring presents with dysphagia on swallowing solid food, but not with thin liquids, due to the mechanical obstruction. Some non-genetic causes of cardiac anomalies are shown here. Intrauterine infections of the torch variety may cause a persistent patent ductus arteriosus. In particular, rubella can cause pulmonary artery stenosis as part of a triad including cataracts and bilateral cochlear sensory neural hearing loss. Maternal autoantibodies can pass transplacentally to the fetus to cause neonatal lupus. Congenital atrioventricular block and extracardiac manifestations such as thrombocytopenia, hydrocephalus and skin rash are common complications, and although the extracardiac manifestations usually resolve after 6 months, the heart block may not, and the child may require a permanent pacemaker. Endocrine conditions such as congenital hypothyroidism may cause left ventricular systolic dysfunction and arrhythmia, whilst maternal diabetes can result in a wide range of malformations, including that of great vessels. Drugs such as thalidomide, lithium, valproate and alcohol may cause cardiac malformations as well. Even if CHD is not associated with any genetic or non-genetic cause, it can coexist with extracardiac manifestations including dysmorphism, restrictive lung disease, nephropathy as well as epilepsy. This slide shows the medications the patient may be on. ACE inhibitors and angiotensin receptor blockers may be started in patients with moderate to severe heart failure, and should be stopped 24 hours preoperatively to avoid prolonged hypertension on induction. Digoxin is usually started in patients with atrial arrhythmia, and should also be discontinued 24 hours preoperatively, as levels may be toxic postoperatively. Beta blockers should not be discontinued acutely preoperatively as it can cause rebound tachycardia, whilst diuretics can be continued with the consideration that preload may be reduced. If the patient is on prostaglandin E1 to keep the ductus arteriosus open, the dose may be adjusted perioperatively to avoid overcirculation under anesthesia. Immunosuppression, if any, should be continued to avoid transplant rejection. Warfarin may have been started for previous transcatheter intervention or implanted prosthetic heart valves, shunts or conduits like the Fontans, as well as conditions such as Kawasaki coronary aneurysms, bicaval pulmonary anastomosis, and dilated cardiomyopathy with severe left ventricular dysfunction. The perioperative management of warfarin will be mentioned in the next slide. As far as possible, antiplatelets such as aspirin or clopidogrel should be continued. Other non-cardiac medications that should be continued perioperatively include asthma inhalers, proton pump inhibitors for gastric reflux, antiepileptic drugs, as well as nutritional supplements for poor growth. The management of warfarin for elective cases depends on the balance between bleeding risk and clotting risk. For patients going for these surgeries with low bleeding risk, there is no need to stop warfarin. For patients with low clotting risk but going for high bleeding risk surgery, warfarin is to be stopped for a short duration, without need for bridging. In patients who have moderate to high clotting risk instead, some bridging with heparin or low molecular weight heparin is recommended. Heparin is preferred for younger children. In urgent surgery within the next 24 hours, the warfarin anticoagulant effect can be reversed with low-dose vitamin K. For emergency surgery that cannot be delayed, both low-dose vitamin K and fresh frozen plasma can be given, guided by point-of-care coagulation profile. Preoperative preparations encompass several facets. This includes preoperative fasting, which is conventionally up to 2 hours preoperatively for clear fluids, up to 4 hours for breast milk, and up to 6 hours for formula milk. Dehydration and hyperglycemia should be avoided in small infants below 6 months of age, children with cyanosis or polycythemia, and those with cardiac lesions that are preload dependent. If possible, these patients should be admitted 1 day preoperatively for IV hydration when nil by mouth, and if the case is delayed, oral hydration should be continued. The timing of the last meal and drink should always be reconfirmed with the caregiver. Pre-medication helps to smoothen the induction process for the patient. The goals are to reduce preoperative anxiety, facilitate parental separation of the patient, improve cooperation at induction, and lower sympathetic drive. However, in children with cardiac disease, the benefits and risks must be weighed carefully. The risks include sudden cardiac decompensation due to the loss of sympathetic tone and systemic vascular resistance, and bradycardia. The margin of safety for adverse effects may also be narrower, especially if multimodal premedication is used, or if the patient already has a difficult airway. These risks may be mitigated by premedicating the patient in a monitored area, however this depends on the availability of resources. In assessing the patient for whether premedication is required, one first needs to build rapport with the patient and family, and it may be useful to gauge pediatric anxiety based on some tools such as the modified Yale Preoperative Anxiety Scale, which looks at the child's activity, vocalizations, arousal and emotional state. Some risk factors for extreme preoperative anxiety also include high baseline child or parental anxiety, previous negative experience with induction or hospitalization, and the age group of 1 to 3 years old, as they have stranger anxiety and tend to be non-rational. Besides the pharmacological management of anxiety, of which there are multiple routes and drugs available, other non-pharmacological methods may be utilized. This includes behavioral preparation programs where the patient visits a play therapist and/or the operating theatre a week before the surgery, distraction techniques with toys or augmented reality videos, and finding out and addressing the child's concern if they are old enough to express themselves. Parental presence at induction is controversial. If the parent is anxious, it may jeopardize the induction process of an initially calm child. According to the American Heart Association 2007 guidelines, which are still applicable today, patients who are at high risk of developing infective endocarditis, or adverse outcomes, and are undergoing only specific types of surgery which may result in hematogenous spread of skin or mucosal commensals, will require antibiotic prophylaxis. First-line prophylaxis includes either oral amoxicillin or intravenous ampicillin, whilst patients who are allergic to penicillin may take clindamycin, cephalexin, azithromycin or clarithromycin. The final part of assessment is risk stratification for surgery. The risk of intraoperative cardiac arrest during non-cardiac surgery is 10 times higher in a child with congenital heart disease as compared with a normal child, and 60 times higher during cardiac surgery. 1 in 10,000 of these cardiac arrests are attributable to anesthesia. Based on the Pediatric Perioperative Cardiac Arrest Registry in the United States, the children with the highest mortality rate are those with single ventricle physiology, severe aortic stenosis as well as cardiomyopathy. These also form 75% of the pathology in children who die from perioperative cardiac arrest. Out of these patients, 75% are also less than 2 years of age. More information on risk stratification will be given in the 4th lecture on this series, on anesthesia for children with CHD undergoing non-cardiac surgery. Thank you for listening to this lecture. Evaluation of the child with congenital heart disease may seem daunting initially, but once you are able to recognize the contributions of each pathology and presentation to the clinical picture, it becomes much easier to assess the child. Please test your understanding with the following multiple